My name is Jason McGhee. I am from HCC, and I'm one of the second-year students. And the report is actually on radionuclide therapy. I'm actually going to present this today. There's 5 different radiopharmaceuticals I'm going to go over. I'll give a kind of a brief history on it before I get into the use of it, and then I'll tell kind of how it's used and what kind of feature of it is. The first 2 will go that way, and then the last 3 are first, second, and third generation radiopharmaceuticals used in the treatment of metastatic bone pain. So I'll go over what METS is and the different types of damage that can occur from it, and then give the brief overview of the radiopharmaceuticals themselves. The first one I've got is Iodine 131. It was in 1938 the isotope was discovered. Discovery made by Glenn T. Seaborg, which is the guy on the left, and John Livingood, the guy on the right. And it was discovered at the University of Berkeley. It's their experiments that led up to the discovery of it were for the fascination of exploring a new frontier of science. Discovery came about when Livingood would perform cyclotron bombardments, which is a very dated cyclotron there. And Glenn would take the target materials and section them out chemically, which would look like this. By measuring the radioactive characteristics of each of the separated materials, Seaborg could determine which isotope and element of, or which, they could determine the element and the radioisotope of the remaining material. Cobalt-60 was also done by was discovered by this way as well. As the years went on, many uses of I-131 were discovered. In 1941, Saul Hertz administered the first therapeutic dose of I-131 in treating thyroid cancer. He also used it in treating hypothyroidism and Graves' disease, and used it as a regular tracer. After many experimental trials with I-131, most of which proved to be quite beneficial, the DEA finally approved it for thyroid patients. And it was actually the first radiopharmaceutical approved for nuclear medicine. After I-131's approval, advancements were made in monoclonal antibody treatments through I-131 tagging. Steve Larson and Jeff Carasquillo treated malignant melanoma, on the left here, with I-131 tagged monoclonal antibodies. And further studies of radiotagged monoclonal antibodies would lead to non-Hodgkin's treatment in both I-131 and yttrium-90. I'll actually have the slide on the right here again, because I would like to outline the CD20 antigen that's expressed up there for the B cells. It's actually got 3 of the antibodies used for it. One is who's from Rituximab, or Rituxan, I'm sorry, is the trade name for it, and it's got Zeppelin and Dextar, which I'll go into a little more detail on later. I-131's main uses include the treatment of hyperthyroidism, thyroid carcinomas, and non-Hodgkin's lymphoma. For any of these therapies, mentioned precautions to be taken based on the dosage given to the patient. Ultimately, the patient will determine how well the contamination is controlled while unsupervised by staff. So, patient education is kind of a big deal whenever you're dealing with iodine 131. For high doses, the patient should be informed that no contact should be had for anyone for 24 to 72 hours of administration. I'm just kind of going over this precaution list and getting into the basics of it. As you can see, it's quite lengthy, and whenever you actually get into practice, you'll go through this whole entire thing. You just got to tell them to be mindful of their excretions. You got to flush the toilet multiple times. Keep their clothing separate from regular clothing, so none of that is contaminated. And time spent with them should be kept to a minimum. Hospital staff also have to take precautions with an I-131 patient or any radioactive patient. It includes visiting. You have to time the visiting hours for patients, watching over anything that could be contaminated, as mentioned above, and preparing the room for the patients as well. Plastic wrap. You just use plastic wrap, and you just wrap anything that is likely to be contaminated, like a desk or silverware or the bed. It's actually not really done all that much these days. I know Tampa General just recently stopped doing this stuff, maybe about 3 or 4 years ago. So you might not see this stuff as much. For lower doses of I-131, the precautions are similar, but to a lesser degree. Patients should still remain confined for about 24 hours, but normally the visiting times are a little bit longer. In most cases that require I-131 therapy, the thyroid is the source of the problem. The only exception to this is in the treatment of non-Hodgkin's. The thyroid actively takes up iodine in efforts to produce T4 and T3. When iodine is ingested, it is taken and transported by the sodium iodine pump. And it's the presence of T3 and T4 in the body that, at equilibrium, that keep us in our normal metabolic state. When there's too much or too little of each, It'll put us in a state of hyperthyroidism or hypothyroidism. If a patient has hyperthyroidism, they satiate with much greater amounts of food and appear to lose weight. People experience tremors, lose sleep. You can normally tell when somebody is hypothyroidism. Whenever you're interviewing them, they're a little more jittery and they talk a lot more. And normally we'll do whenever ion-31 therapy is performed, it's also done normally after surgical removal of it. Ion-31 decays with both beta and gamma decay, the beta decay being the primary reason for the isotope's use in the treatment of hypothyroidism. It's for this reason that it's also used for thyroid cancer treatment. The beta particles are quite easy to block outside of the skin, as plastic is more enough to attenuate most beta particles. But when beta particles make contact with the tissue inside of the body, slow destruction of the tissue occurs, this is called ablation. It either reduces the release of T4 or T3 or it just stops it altogether. It is by ablation that I-131 is also used in treating thyroid cancer after post-surgical removal of it. Some people say that when performing the ablation under almost any circumstance, it's good to just completely ablate it so that they don't have to, in the case that they become hypothyroidism again or have hypothyroidism again, they don't have to get any additional exposure or anything like that. So it just completely cancels that out altogether. Unfortunately, they'll have to be on artificial hormones for the rest of their life because they can no longer produce the T3 and T4. The other scenario in which I-131 would be used is in the case of B-cell non-Hodgkin's lymphoma. And this is the only treatment that is not intended to affect the thyroid. In fact, a saturating chemical, or a luteal solution, has to be taken 1 day before and for the duration of the actual treatment, so that none of the I-131 is taken up by the thyroid and it goes to the non-Hodgkin cells instead. Monoclonal antibody treatment for non-Hodgkin's is performed by utilizing the CD20 antigen, which I've got up here. Early and current treatments of monoclonal antibodies use a chemical called rituximab, which is the first generated antibody of its time, and it has proven to be very effective, at least much more so than other treatments at killing off these CD20 expressing cells. It does so by 3 mechanisms. It's got complement-dependent cytotoxicity, antibody-dependent cellular cytotoxicity, and induction of apoptosis. Unfortunately, the treatment is not guaranteed to cure non-Hodgkin's. About 50% of the patients will see recurring non-Hodgkin's in their lifetime, and a lot of them won't actually be responsive to this chemical. So the next step would be to utilize the I-131 therapy. That I'll let you sound that out yourself. So, in any case, I believe it's Zephlin, or Zephlin is the trade name for it. It's an effective inducer of apoptosis on its own, and it forms a strong covalent bond with I-131. So it's actually seen as a pretty good follow-up to the original therapy. And since the procedure uses a lot of additional chemicals compared to the I-130 therapies before, other considerations have to be taken into account. Bone marrow involvements have to be less than or equal to 25%, platelet count greater than 100,000 cells per microliter. Neutrophil counts have to be greater than 1,500 per square millimeter. No previous myeloablative therapies with bone marrow stem cell replacement, and no allergies to the proteins or iodine being used. And obviously, if any of these aren't met, you can't actually do you cannot have the therapy. As far as what goes into it, it's done in pretty much 2 phases. You have the distribution stage, which you'll give the luteal solution. Then you'll get the cold antibody, infused over about 60 minutes, followed up by a 20-minute infusion of the kind of like the test run. It'll be tagged. The antibody will be tagged with the isotope at about 5 millicuries. You have to come back every about 2 to 4 days for a checkup, and then again at 6 to 7 days. And so long as the biodistribution is good, then they're good to do the therapy. Which the process is about the same as the biodistribution, just you're going to give them an actual ablation dose. And it's about 100 to 200 millicuries. And then the patient will just return to the hospital based on the protocol. The future of I-131 therapy lies in the treatment of neuroendocrine tumors, and the diagnosis with I-123 MIBG trials have been proven with I-131 labeled peptide somatostatin receptor ligands. These ligands have proven to have a high affinity for specific reactions for receptors of neuroendocrine tumors, and although the tests have shown much promise for these compounds, they're still not available for clinical practice. The next radiopharmaceutical is yttrium-90, and to determine the exact discovery of it, you have to kind of identify strontium-90s first, because strontium-90 is a byproduct of fission reaction between uranium and plutonium. These reactions take place around nuclear reactors, and they're kind of like fallout of nuclear weapons. So in the 1940s, 50s, and 60s, you can find them, or you can find this stuff all around the world. When strontium-90 decays, it decays to yttrium-90, and simply milking the generator will allow us to use yttrium-90 for its clinical practice. And that is not actually strontium-90. In clinical, yttrium-90 has two primary uses, the first of which is the treatment of non-Hodgkin's lymphoma, going back to the CD20 slide. The treatment is very similar to it in that it's tagged to a monoclonal antibody, but the only thing that they differ in is that it's got a different precursor for the biodistribution stage. Instead of actually using yttrium-90 to tag with it, it uses indium-111 for it instead. But other than that, it's pretty much the same deal. And the trade name for it is Zeppelin. The last one was Bexar. Zeppelin was developed and approved in February 2002 by a company called Biogen. IDEC is the first radioimmunotherapy to ever be approved by the FDA. Contradictions to it are also the exact same as the I-131 therapy. Although both iodine-131 and yttrium-90 therapies are very similar in nature, neither is yet to be proven more effective than the other. Both have anywhere from a 63 to 75% effective range in individual studies. The second use of yttrium-90 in clinical treatment is, in the treatment of unresectable biocellular carcinoma or tumors. This is done through the use of microspheres. These microspheres were originally developed by John Ugelstad in 1977 at the Norwegian Institute of Technology, which this is the gentleman right here to the left. The original particles that he made were much larger than the ones that we use in NucMed, but still it was their uniformity that made them very useful to big business. And due to his connections with Dyno Industries, they were originally called Dyno beads. They were used for all sorts of things: chromatography, calibration of instruments, and optical storage. Eventually, they were made out of different substances. They had glass, proteins, and polymer. The glass and the protein or polymer are the ones that we normally use. And they're also eventually made radioactive for diagnostics and cancer treatment. There are a couple of different brand names that are sold with these microspheres, one of which is Seartech, and the other one is Therasphere. The Seartech are the polymer spheres, and the Theraspheres are glass spheres. They both work about the same way, but they're just used in different scenarios based on the conditions in which the liver cancer, or based on the conditions of the liver cancer. Searspheres are used in the case of tumors, and Theraspheres are used for radiation treatment to assist in future transplant. Prior to the injection of these microspheres, the patient's got to go to interventional radiology, where they will undergo a diagnostic hepatic angiography. The angiogram determines exactly where the veins and the arteries are of interest, in this case, the liver. Once the arterial blood flow has been established, the dose of technetium-99 MAA is ordered, which we'll draw that up, and then we'll hand it over to the radiologist, and he'll administer it through the hepatic arterial catheter. This is kind of done as a test run because there are certain limits that you have to of perfusion through the liver to the lungs, and if it's surpassing a certain limit, then it can't actually be done. And these are the percentages. So 10 to 15% of the MAA passes the lungs. The dose has to be reduced by 20%. 15 to 20% will equal a 40% reduction, and if it's any greater than 20%, then it actually can't be done. After the dose is drawn up, the vial of microspheres is to be taken and placed in a delivery system, which looks like these. I know there's a couple of first-year students here. If you guys have the opportunity to check this out, I know Tampa General did a few of them while I was there with these Searspheres, but definitely check this out because it's really interesting to see how it's all put together and how they use it over in interventional radiology. The glass spheres are suspended in normal saline and linked to a bent vial with a high-pressure infusion device, which is the one on the right, and got a little black arrow there for the infusion pump, which it agitates the particles upon administration. The polymer spheres, which would be the ones on the left, they're suspended in sterile water. It's got like a little container there right in the middle where it keeps all the microspheres, and it's linked to a three-way stopcock over here where you can see his hands. He's got the three-way, and one is just for the infusion to push the microspheres through, and the other one is contrast, so it kind of monitors as they go in. And whenever they are actually pushing this through, they have to do it in short bursts so that it's not to push any more through the liver and into the lungs for any kind of shunting. After all this is completed, patients could leave the day of, and then they check back in every 2 to 3 weeks or so. Although this isn't actually a cure for cancer, it does show signs to be much more effective in fighting it. The combination of the radioactive spheres and chemotherapy, in many cases, patient survival has extended for several more years. In the coming years, they'll be making new spheres compounded with different effects, hopefully yielding better results. For the last thing that we treat is metastatic bone pain, and this is obviously a couple of horror stories here. The three that we use for it is phosphorus 32, strontium 89, and samarium 153, and they kind of go in different generations. The purpose of using all of them is for the treatment of metastatic bone disease. It's different than regular bone cancer in that it didn't originate in the bones themselves. The cancer will normally start from another organ, and then it'll just kind of leach to the bones after a while. It can also bring about pain. It brings about pain at the site of infection. It can weaken the bones that are affected, and it leaves them for more chances of breaks and fractures. And this can leave a patient bedridden for quite a while. Looking for the sites of infection, the most common bones are the spine, pelvis, ribs, skull, upper arms, long bones of the legs. Of these sites, there are 2 types of damage that can occur. You have osteolytic and osteoblastic. Both of these types have different forms of cancer that are associated with their presence. This is osteolytic. It pretty much, it just eats away the bone. No remade bone going in its place. It comes more commonly from the spread from lungs, the lung, liver, thyroid, and colon cancers. And the other one is osteoblastic, where we're seeing more bone being produced at the site of cancer. And the reproduced bone here comes out deformed and it's weak, and it just leaves the patient more susceptible to what are called pathological fractures. So they could just be doing whatever in daily life and just break. And this often comes from the bladder, the prostate, and stomach cancer. Regardless of what type of bone pain the patient has or where the origin of the disease was, a lot of remedies have been made for the bone or for bone pain, and ours are these 3. Phosphorus 32 is the result of a neutron bombardment with phosphorus 31. It's a pure beta emitter, and it's got a pretty good history with nuke med, and from the discovery of other biological processes. In 1935, George D. Hebsey and O. Shivitz used the phosphates labeled with P32 to demonstrate renewal of bone constituents in the bone. This demonstration was done in rats and it later lead up to the bone pain treatment that we have today. In 1936, John H. Lawrence demonstrated the P32's therapeutic value in treating leukemia. This was the first time an artificial radiopharmaceutical was used in a treatment. And B. Silverstone used P32 to detect brain tumors with the use of a detector probe during surgery. And this is the P32 is actually the first generation of this. It's not used anymore, or if it is, it's very, very rare. Whenever it is administered, it localizes hydroxyapatite crystals of the bone, which 70% of the minerals in the bone are made up of. Although it can be found in all bone tissue, most of it will localize in the area of highest bone formation, which will be the area of infection or damage. There's 2 routes of administration. The first route is just an injection of 5 to 10 millicuries. The other one is oral ingestion, which is about 10 to 12 millicuries. The second one is strontium, or strontium 89. It is most commonly produced from neutron bombardment with a strontium 88 target. It is a calcium analog, and the dose of it is also very small, being a range of 40 to 60 microcuries. and it's got a half-life of about 55 days. And of the 3 radionuclides we use for bone therapy, samarium-153 is the newest and probably the only one used. The element samarium was originally discovered in Geneva. It's used, obviously, for metastatic bone pain. It's created from bombarding samarium-152 in a nuclear reactor, and unlike the other 2 radiopharmaceuticals, it's the only one that doesn't have an initial affinity for being taken up by the bone. It's got to be cleated to aminocarboxylate and aminophosphorylate ligands. The trade name is called Quadramet, which, as some of the other clinical sites that you'll go to, they've actually got normally stand-up advertisements for this. I've seen them in a couple different places. And the dose itself is about 1 millicurie. Over 2/3 of the dose is excreted in the urine within the 6 hours of injection. When using any of the treatments for bone pain, you have to have a couple of, or quite a few tests actually performed to make sure that it is actually ideal for the patient to take, which are all of these. Bone scans have to be performed within 4 to 8 weeks of the therapy. All other radiation therapy should be done 6 to 12 weeks prior to bone therapy to prevent severe leukopenia or thrombocytopenia. Platelet count's got to be 60 to 100,000 per milliliter. Leukocyte count is 2,000 to 3,000 per milliliter, and granulocyte count is 2,000 per milliliter. The next week after the injection, the patient just has to come in and make sure, or the next week after the injection, the patient has to make sure to keep transferring body fluids to a minimum or avoid them altogether. To wash your hands thoroughly after after using the bathroom. And the future of bone treatment lies with samarium-153. There are now a few cytotoxic bone targeting chemicals used in conjunction with it to fight against the pain and hopefully cure the disease itself.